Okay, good morning. I want to speak about the new technology, the new designs and research in urethral stents. This is the three pillars that we are improving the urethral stents. This is about we need to improve the biomaterials. We need to improve the coatings to avoid the biofilm formation and incrustations related with new designs. We spend more time using the double J urethral stents, and among coatings and designs, we have the new designs of the drug-eluting stents. I want to speak about the first is biomaterials. Yesterday I speak about these new biomaterials. The first to improve the biodegradable urethral stents is about metallic stents. We use the research groups mainly use the alloys of magnesium, silver or zinc. Remember yesterday, have a very good biocompatibility, and of course, these alloys magnesium have a good results to avoid biofilm formation. About the biodegradable urethral stents, polymeric stents, we have the natural polymers, mainly alginates, and the synthetic polymers is the same that we are using every day in the operating theater, because it's used as a suture in our surgeries. And I want to introduce a new biomaterial. It's not, of course, a new biomaterial, because silicone are all biomaterial, but right now we are improve the silicone, because the silicone was the first biomaterial that we are manufactured the urethral stents, but I think that right now we have a revival of this material. And what is the reason? The reason is the biofilm is the incrustation, because there are many research and clinical research about that silicone stent demonstrate that lower 20% lower rate of biofilm formation and 35% lower rate of incrustation. And for the patient it's important, because when I change the double J in a long-term stent duration, maybe the second option was silicone after the polyurethane removal stent. The second pillar of this research is the coating. I want to thank to Professor Halinsky, because he introduced all of my research about this. We need to cut the formation of biofilm, and we need to improve the coatings to place new biomaterials or new coatings to the surface of the double J urethral stents, because the biofilm is related with urinary tract infection, symptomatic bacteriuria, and of course incrustations. But we have a big problem, and it is that we always right now use antibiotic-free solutions, and this is because we need to comply with the European Union regulations about the antimicrobial resistance surveillance in Europe. There are, as explained very good Dr. Halinsky, we need always use antibiotic-free solution to coating or double J stents. And I don't want to speak about all of the strategies about this, but I think that the most close to the clinical studies or the clinical trials is the antimicrobial peptides, to cover the stents and to avoid the attachment of the bacteria, okay? Because antimicrobial peptides is a very short proteins that have a bacteriostatic and bactericidal properties. I think it's a good solution, it's a new strategy. But we have a problem, because I think that we are only view the problem in another side, and we need to see in the other side of the mirror, because if researchers can respond all of the or develop a new coatings to avoid biofilm. I think that we need to change our mind about this. And if we have problems with the urethral stent, it's because they are inside of the urine and inside of the body. And we need to modify the urinary environment. And what is one of the strategies is to change the pH and to increase in the urine, to modify, to introduce another crystallization inhibitors. Okay? There are scientific evidence that if we change the pH and we add inhibitors, we have less incrustation, and in many cases, like canoxidine, reduce the number of bacterial adhering to the surface of urological device, not only urethral stents, also bladder catheters, by more than 10 times. This is important because we are waiting for the researchers like me to improve the urethral stents, to improve biomaterials, to improve the qualities, but right now we can't fight to change the environment of the urethral stents. Keep in mind. I think that one of the most important developments in research is the drug-eluting stents. Right now there are 3 groups working on that. The first and the second is in the same way because it's to inhibition of the recurrent urethral stricture after endourethrotomy or after balloon dilation of the urethral strictures. The first group was or released drugs like rapamycin that blocks the mTOR pathway because the mTOR pathway is related with fibrosis in the second helix of the urethral tissue. The second research line is the pirfenidone that is similar because they reduce the expression of the TGF-beta and reduce the deposition of collagen. This is very important because in the same urethral stent we have released the drugs because we are in the 21st century and we think that, of course, urethral stent improves the upper tract drainage. Of course, we need the scaffold function of the double J, but we have a medical device inside of the body. It's possible that release topical drugs. Yes. Right now, yes. And our research group are developing in the last 7 years. This is not soft research. We spent the last 7 years to achieve these results. And we are working to release in our bilateral urethral stent with a polymeric matrix to release mitomycins to intracavitary instillation of cytostatic to adjuvant therapy of the upper tract urothelial carcinoma. There are more than 25 research involved of this research. And this is our first research, first always in lab studies. We perform in vitro studies to control our polymeric matrix that's released in the first 12 hours the mitomycin inside of the artificial urine. The second step was studies in urothelial carcinoma, human urothelial carcinoma cell cultures to achieve or to control that we are the possibility of reduce the viability of the carcinoma, and we have a very positive result. We decreased 53% of the viability of these carcinoma cells, and these results encourage us to perform the first animal model assessment of our coated mitomycin eluting bilateral urethral stent for the intracavitary instillation of the adjuvant therapy in upper tract urothelial carcinoma. This is our results. Of course, we have a big complication. We have a low success rate. This is only research, and the next step is increase, and the next step, is to have more studies to improve our success rates. But for stent research, I think that it's not about the stent. I think that for stent research or in this forum is the polymeric matrix that has able to release drugs in a controlled and predictable fashion. If we have a good polymeric matrix that release drugs, we can change the drugs, and it's possible to release or to change with these drugs to change the environment that we have uretral stents, to release inhibitors, to change the pH, maybe. But right now, we are working only with mitomycin, but it's an open research. And my last slide is about the designs, the intelligent designs, the intelligent stents, because there are few research about this, but there are many. Sorry. Sorry. It's a microsensor, because there are a very tiny sensor that in the case of this research is only for the pressure, to control the pressure inside of the pigtail, in the PLE pigtail, that have information about the transponder, and we can control with alarm in your phone that you are increasing your intrarenal pressure before that you have pain and you have a renal colic. This is only the first study, but maybe it's possible to have another microsensor to control the pH, the bacteria, or to stimulate peristalsis, to restart the peristalsis, so modulate the peristalsis after when you have a place of double J urethral stent. Thank you so much for your attention.
Thank you very much. Any comment, questions? As you know, it's more than 40 years that we had the stent introduced by Finney, and still we don't have the ideal stent.
Yes.
I'm happy to hear that we have intelligent stent, but we need intelligent doctors and patients initially.
It's the first.
Yes. I want a couple of more clinical data that you have for canoxidine, because it's a solution that it's available in many countries. I've been using it, but it's a few months experience that I have. What is your long-term experience by giving canoxidine according to your studies or according to the experience that you've shared with other clinicians?
Okay, I think is to see in the other side of the mirror, because we have a problem that is the urethral stent, and we are waiting for improve the biomaterials, the quitting, but it's very difficult. But we can change the environment that the urethral stent are inside, because we can change the pH urine, and we can add inhibitor crystallization inhibitors. For us, it's easier, and right now, for example, in my opinion, canoxidine is a good idea because add 3 different products that have a wide range to avoid more of the 50% of the problems that people have with double J stents. Okay, but in the future, maybe it's possible that there are not only one canoxidine that very specific for a urethral stent that you have. But right now, it's the best option because it's too safe. This is one important because in research, and because add to the double J stent, maybe in long term, of course. This is a big problem. But I think that change the environment that the double J are is a good strategy.
Yes.
We need to.
And it's the only thing that we have which has proven efficacy. Please, Dr. Hess.
Thank you very much. L-methionine is one of the compounds in canoxidine, and if you acidify the urine, that's nice, but it will also acidify the whole organism. If you acidify proximal tuberous cells, you will get hypositraturia. If you acidify the bone, you will get bone dissolution and hypercalciuria. Now the question is whether you like that or not. The
problem is multifactorial problem. not only one gun for this. It's like the previous speak. It's multifactorial. There are many, it's about bacteria, there are many adhesins, and about minerals, we need to understand and to know what is your patient, to study the urine and to study the crystals. Okay, this is the problem.
Okay, and a last question regarding the all silicone stents. I know that there are several colleagues and friends like Professor Traxer that are fans of the all silicone stents. I've came across the last 3 months of 2 cases of neurological patients that had for nearly a year all silicone stent, and when we tried to exchange them, the stent came out into small pieces. So there is no one-size-fits-all. It depends with the patient if he has chemotherapy, hydration. So the whole environment should be considered. But it's not the ideal stent from my point of view, the all silicone, because probably it's very soft or very fragile.
Of course. I think that not for the first time, but you have problems in a patient and you need to rechange. Maybe it's an option because decrease the biofilm formation and decrease this. But of course, they have a high friction coefficient and the tensile strength is bad. Okay, it is the cause that they fall out for the new polyurethanes. I say that it's an old biomaterial, but it's a revival only in these patients that have problems, and you need to long-term stenting because the bacteria have problems to attach to silicone because it's a different surface than the new, not it's new, but the different patterns of polyurethane.
Thank you very much, and we have to